The next talk talks about cellular therapy in GU cancers. Over the next 15 to 20 minutes, you can relax and try to listen what is happening in this world, and you can forget this after 10 minutes because it will take time for this to come into picture. Now, whenever we talk about adaptive T cell therapy, you need to be clear with respect to three words. What is CAR-T, what is TCR, and what is TIL. Now, CAR-T and TCR are made from lymphocytes, and you need a viral transduction to be done in this situation. So because a viral transduction is done, they're specific for some antigens. TIL is not specific. You take a lymphocyte from the tumor and then expand the lymphocyte in the interleukin-2 well. Now, where does it differ? It with respect to the infiltration. If you look at the third column, CAR-T and TCR have low trophism. But as opposed to that, TIL, in which you are taking a lymphocyte, which is coming from the tumor itself, which has already infiltrated the tumor, has a very high amount of trophism associated with it. So the penetrability of TIL in a solid tumor is much better than that of a CAR-T or a TCR. Along with that, one of the other concepts which you need to understand is, whenever you talk about TCR, you need to know the HLA typing of the patient. In TCR, the antigen presentation is done by antigen presentation cells with the help of major histocompatibility complex. Now, when you have a major histocompatibility complex, which is here, which is presented, at present technology is not advanced to make a TCR for every major histocompatibility complex. Most of the times, this is restricted to HLA-A0201 domain. And this allele in HLA is seen only in 49% of the Indians.
This is the same which we that for the myxoid liposarcoma.
Correct, sir. This is the same which we check for.
This patient first we have to do a HLA.
Sir, if we are looking at a TCR for thing, then there is a library of TCR. So if you want to do TCR for P53, according to different subtypes of P53, you have a library which will tell you for which HLAs this library can be prepared. Same way there is a library for KRAS for different HLAs. Same way there is a library for MAGE-A4. Same way there is a library for New York esophagus 1 antigen. So you need to have the relevant HLA, then only you can target the TCR. It's not going to be, if that is available, if that is in the patient.
Yes.
Yeah. Now, let's look at what are the cellular therapy options which are common RCC. Now, there would be discussions after this. You give first line immunotherapy TKI, second you give cabozantinib, then you may use lenvatinib. But today, the practical situation is most of the RCCs will be looking at your face after third line or fourth line setting with most of the things exhausted if you use belzutifan also in these patients. Now, what are the options for this? And let me go to the structure of CAR-T, so that many of you may have been hearing the talk for the first time. This is the segment which actually identifies the antigen. This is the transmembrane domain, and this is the co-stimulatory domain. Now, the generation 1 CAR-T has no utilization. It does not stimulate. It does not proliferate. The generation 2 CAR-T are the ones, so if you look for CAR-Ts which have got approval for lymphomas and multiple myelomas, all have been generation 2. They have a single co-stimulatory domain, which most of the time is 4-1BB or CD28. The third generation CAR-T has two co-stimulatory domains. Now understand, the modification, it's not that from the third the fourth come. The third is a modification of 2, and fourth also is a modification of 2, and the fifth also, which also is a modification of 2. Now the fourth generation actually have a transgene inducer, which leads to excess of interleukin secretions. And the fifth generation, which I have not shown here, actually has an interleukin-2 gene embedded inside. What this does is, most of the solid tumor milieu is cold. It transforms this cold milieu into a hot milieu. Now, what has been assumed is, higher the generation of CAR-T, more likely they are to be successful in solid tumors. There is one more concept, that there is trafficking issues in the solid tumor, in which the CAR-T may not be able to reach up to the solid tumor. In such situation, you use something called armored CAR-Ts, where you would have a second hyaluronidase gene which has been implicated inside, so that the dissection of the CAR-T dissects its pathway towards the tumor itself. Now, what are the things which are showing challenges or interesting data in um, uh, RCC. If you look carefully, you will see one word, CD70. And if this is the takeaway you can take from the lecture, that in RCC, something called CD70 is coming, and this CAR-T is going to come, and I'll tell you, this CAR-T you are going to see an FDA approval this year, or definitely by the next year. Now, what is this data and how many patients have CD70 positive? Now remember, whenever you do CAR-T, 1% positive, 10% positive does not have a meaning. It is worthwhile doing it when you have either 50 or 60% of the cells which are positive. If you look at clear cell RCC, and the definition of here is 1% positive, nearly 98% of the patients would have CD70 expression. If you look at the definition of more than 25%, then nearly 41% of your clear cell RCC would have CD70 positive classification. If you put the cutoff as 50%, then this number drops to 22%. Now, remember, in all types of CAR-Ts, for lymphoma, leukemia, multiple myeloma, you have been hearing about autologous CAR-T, where the patient cells have been taken, they have been viral transduction done and given back to the patient. This is probably the only site where allogenic CAR-T has come way ahead before development of autologous CAR-T.
So if you give the allogenic, like in bone marrow transplant and all that, what will be the issue with the HLA matching with that?
So,
Is there?
well, I'll come to
Okay.
that, sir. I'll come to that. So, the question is very relevant. If you are going to give allogenic CAR-T, what will be the relevance with respect to HLA typing? So, we all know that mainly broadly two types of lymphocytes, gamma delta and alpha beta. Now, if your allogenic CAR-Ts are going to be derived from gamma delta T cells, they are MHC independent. So you may not have to do any HLA typing in these patients. But if your CAR-Ts are going to be derived from alpha beta, then HLA typing comes into picture. Now, but HLA typing is not done before these CAR-Ts are given. And what is the reason for that? If you could see, the TCR, which is HLA dependent, and the MHC1 are actually knocked off of the CD70 in the CAR-T called CTX130. If you look at LO316, TCR is knocked off, and along with CD52 is knocked off. Does not say that it decreases the what we could say graft versus disease in the patients, but it reduces it to significantly below 10%. Correct. If these two are active, you would have, sir, graft versus host disease seen in these patients. So let's look at these results from cobalt. Healthy donors, sir. Healthy donors. So if you look at the phase 1 of cobalt RCC study, all these patients had stage 4 disease had received at least 3 lines of therapies. And 6 of these 14 patients had actually had refractory disease, and they were smart enough to take patients who have a high CD70 expression, which was on an average 100%, but they had patients from 1 to 100% in this study.
This CD70 ISC expression.
IHC, sir. IHC expression, and the expression has to be on the cytoplasmic membrane, and that too moderate to strongly positive. Well, let's look at the side effects which we saw in this. You could see that only 50% of the patient had cytokine release syndrome, and there were only 3 patients had any serious adverse event out of the 14 patients, like around 30% side effects. 1 patient had a durable complete remission for 18 months, and 69% of the patient had a stable disease, giving a disease control of 76.9%. Sir, this is single cycle. Now let's look at whether the CTX130, when I showed the previous data, at that time the median follow-up was small. Now this was the long-term follow-up and came in April of 2024. Well, that one patient who had a complete response continued it beyond 36 months. And nearly 75%, if you go back to the slide, where it was 69.2%, now there are 75% of the patients who had achieved stable disease, and quite a few of them had more than 18 months, reflecting that the disease control rate in this heavily pretreated population was 81.3%, suggesting it's a durable response. Now, how was the whenever you give CAR T, one of the property of CAR T is it goes in the blood and it has to proliferate and it has to sustain. Now what we have seen in lymphoma and leukemia, that the sustainability is there for around 6 months to 1 year. And what we have seen in certain CNS tumors is that the sustainability of B7H3 CAR T given intracranially or GD2 is for around 545 days to 560 days. Now let's see how was the sustainability which was then, and that would determine in future if they plan to give multiple cycles in these patients. You would see that it was detected within 20 minutes after the infusion. It declined to a nadir in 2 to 3 days and followed by rapid expansion between 7 to 15 days. And at all dose levels, they saw that the expansions of CAR T did happen in the blood. Let's look at the other CAR T, which was LO316, which was there. 18 patients, but out of them 17 patients received it, and all again were post 3 lines of therapy. Now what we see here is 65% of the patients had CRS.
How this differ from the previously LO116?
Sir, they both differ with respect to their both of them are a TCR knockout, and in CTX130 there is an MHC1 knockout. This company had given a CD52 knockout. Along with that, in the CD70 binding domain, there is a rituximab-like switch which has been put so that it decreases the inflammatory response if graft versus host disease. So the basic differences between these two knockouts and this rituximab domain.
So if this patient develops, rituximab can be given to prevent
correct, sir. In fact, in CRS, if it goes uncontrolled, one of the agents after anakinra you can give is rituximab, sir. In fact, you can even give some low dose of chemotherapy also. So what we see here is, as opposed to there was a 12% response rate and a disease control rate of 71%. What was interesting is that the previous investigators were smart that they took patients which had 100% CD70 seen. Here they were not smart. And if you restrict this analysis to patients who were CD70 confirmed tumors, you could see that the response rate was 22% and the disease control rate was 100%, suggesting that if you supra-select your patient according to CD70, it would be something reasonable. Now, what does CD70 shows is it's an allogenic. Now, those of you who have used autologous CAR T know that 1 month goes in making the CAR T and giving it back to the patient. The beauty of allogenic is there is no waiting. The GVHD risk is there, but it is within in the first 1 to 10%. And you are seeing reasonable disease control rates in this. And what this led to is, it led to a fast track designation for CD70 CAR Ts for its development. And that's why I suggested if this responses do confirm, we might see a breakthrough or a conditional approval being received for.
But the problem is that then that allogenic will be the property of that company.
Yeah, that allogenic will be
but
a property
autologous will be the individual.
Sir, so what it also helps is, if you get an allogenic CAR T, it would be an off-the-shelf CAR T. It would be more scalable and the cost would drastically come down with respect to what is the cost of autologous CAR T at present. Let's look at whether there is a role for TCR in RCC. And this is one of the data for TCR which has come in RCC, where you are looking at human endogenous retrovirus type E, which has been targeted by TCR in RCC. And here, again, whenever you talk about TCR, you need to look at the HLA domains. And what you could see is that there was some response, which was 7% partial response, 29% stable disease. So not as interesting as what you see with the CD70 CAR Ts. What could be the role of tumor infiltrating lymphocytes today? Now, understand, whenever you want to give TIL, it gets tagged along with high-dose interleukin-2. Now, those of you who would have done your medical oncology in the first decade of 2000 know that this was considered as one of the curable treatments for RCC, with 17% patient going into long-term remission with high-dose interleukin-2 itself. Now, if you want to give TIL, it has to be given with high-dose interleukin-2. And there were 2 papers which came in 2025 ASCO Genitourinary retreating the role of TIL with high-dose interleukin-2 in RCCs. And this I go back to the old paper where you could see that nearly 25.5, 10% complete response and 25% is partial response, which actually is much better than what has been shown by the allogenic CAR T. And these responses have duration which is durable for beyond 2 years in these patients.
It is as good as immunotherapy current.
Sir, it is actually better than immunotherapy, because these patients were post more 3 lines of.
I think we said
of
go back to the high dose interleukin era.
Sir, I think the reason why we left high dose interleukin 2 is because we lost the
Toxicity.
skill set of
Yeah,
managing
it has
the
to be given in
toxicity
ICU.
of- Yeah, it has to be given in ICU. We now have given it to 7 patients, and every patient, none of the patient has completed all 6 doses of, the highest patient which has completed for 5th dose. There will be capillary leak syndrome, there will be high rigors which are seen in these patients. With that, we'll go to what's the role of cellular therapy in prostate cancers. Now, prostate cancer, if you look at the way it has heterogeneity, antigen escape, and there are multiple antigens which are seen in prostate cancers, and some even say that this is one of the ideal model for developing CAR T. The 2 most promising things which have come is this antigen, PSCA and PSMA, and we will be discussing the results of these both. Let's look at the PSCA CAR T, and now this CAR T is actually it was given in castration-resistant prostate cancer, and it was actually an autologous CAR T. So you would see that there is a harvesting done, there is a delay of around 3 weeks, then there is a CAR T infusion, and the patients were followed up for a year in this situation. Now, if you see, all the patients were heavily pretreated, all had exposure to all the known agents which are given in prostate cancer. Now, what we saw in these patients was, in such heavily pretreated patients, we saw that there was a response which was seen in nearly 1/3 of the patients. There was cytokine release syndrome seen, but that was limited to grade 1 and grade 2, and you actually got sustainable response in these patients. Now, if this data gets confirmed in a large cohort expansion study, we are looking at a new treatment option. Now, a warning with respect to PSMA. PSMA actually gives better decrements, but remember, PSMA is expressed also in liver, also in lung, and also in brain. Now, the development for PSMA had to be stopped due to severe neurotoxicity which was seen in these patients. Now, what has come with respect to PSMA is logic gating PSMA, where you logic gate it for loss of heterozygosity, which is not there in the tumor but present in the normal tissue. So if both of these things are seen, then the PSMA CAR T gets activated, but that at present is undergoing a phase 1 testing. What is interesting is adaptive transfer of gamma delta T cells in prostate cancers, and especially if they are given after a zoledronic or better pamidronate injection in the prostate cancer patients. Now, gamma delta T cells are seen in only 5% of your T cells, and they are very intelligent cells and actually modulate the response to your cancer treatment. Now, if you get gamma delta from healthy donors and make a high purity gamma delta, that is data, if you give it to the 200 to the power 10⁶, it actually targets MICA A and MICA B antigens, which is seen in 75 to 95% of prostate cancers. And this is the data where you could see that at 12 months, if you give gamma delta with zoledronic acid, nearly 80% of your patients are not going to progress even if they have received multiple lines of treatment. Now, that was gamma delta adaptive T cell. What if you make a CAR T out of gamma delta? Now, this has actually been studied for PSCA CAR T, in which this would be an allogenic CAR T which would be made for gamma delta, and it has started showing good response rate at present and undergoing phase 1 testing at present. Now, in prostate cancer, we all face it, that is neuroendocrine differentiation, which we have started seeing. Now, this is DLL3 BITE, and this is data for neuroendocrine tumor. What I'm showing you is the results which came in small cell lung cancer with a DL3 specific BITE, which is called tarlatamab, in which in small cell lung cancer, where hardly any patient survives beyond 1 year in second line setting, for the first time you saw with 10 mg dose of tarlatamab, median survivals going to 15 months. But does this would get replicated in other neuroendocrine sites of the body? And there is data to this suggestion that this even after 2 lines of therapy, does get replicated in neuroendocrine of prostate and bladder with response rates of as high as 42% and duration of response which is 1.5 years or beyond in these patients. And the question is, those of you who would have used tarlatamab or BITE know that they are short acting, they have to be given repeatedly, and believe me, the first dose of tarlatamab is just as good as hell because you need the patient to be in ICU because CRS is going to be developed in this patient. So what if you give a single agent of CAR-T before DLL3 which could have similar efficacy results in these patients? Another interesting thing which is coming up with respect to CAR-T autologous is development of such kind of transform BiTEs by giving a single B cell infusion. Now we all know that all antibodies are produced by plasma cells. We make the antibodies with the help of hybridoma technique. Now what if you make a plasma cell genetically which in the blood itself keeps making the antibodies at a secreting volume which you require, and there would be a death switch which stops it from developing after a year. The phase 1 studies for this has already started and 4 patients have already got recruited, and you might see a new era in medical oncology where for trastuzumab, pembrolizumab, you might not be calling the patients again and again. You might be giving a single infusion of B-cell infusion and the patient will auto-generate its antibody on its own for the rest of his life. Now, two sides of germ cell tumor. Now, we know that the treatment of germ cell tumor is quite successful, but we do land up with some patients of germ cell tumor which don't do well. Now, there are 2 targets in germ cell tumor, Claudin-6 and IPCAM, which have come up with very good. Sir, my slides de dunga aapko. So, what it is showing is, this was the data of phase 1 trial for Claudin-6 and for IPCAM, which did show that around 20 to 30% of this heavily pretreated germ cell tumor do respond. I'll show one case which we did, which was a 43-year-old male. He was previously treated with BEP, EP, TIP, VIP, GEMOX. He was resistant and refractory. Twice he was counseled for to do transplant. He didn't agree. और वो कहते ना एक time पे कर लिया तो बच जाता. Now he had to do a CAR-T. Now we did a CAR-T panel for this, and the whole CAR-T panel has been validated by the Newburgh lab by Dr. Jay Mehta, and GPC3 came positive. Now we did give him a GPC3 armored CAR-T. He had a CRS, neutropenia and thrombocytopenia, and it was very severe reaction in this patient. But the thing was, at the end of 2 months, when we saw the response, this was seen, and now he's due for his 4th month scan. He's doing still well. You could see a good partial response which was seen in this patient. With that, I would tell you that gamma delta T cell adaptive trial is running at our center. We are doing it in 10 cohorts. Enrollment has started from 1st of April. We already screened 15 patients. And you could see cohort 9 is RCC and cohort 10 is prostate cancer. It is one of the largest trial for adaptive cell transfer. The phase 2A endpoint is response rate, and you would hardly get a phase 2 which would look at OS as an endpoint. The cumulative strength of the study is 450 patients, and this has been sponsored by the Singapore government. Along with that, we have quite a few phase 1s which are going on in solid tumors, 5 actually, in which there are newer agents of immunotherapies and vascular agents which have been tested. So I would request, if any one of you have such patients, please consider sending it to us. So to conclude, definitely cellular therapy is showing promise. It's not yet ready for routine use. It requires more study, but it does give a hope for them where currently no treatment options are available. With that, I'm really sorry for exceeding the time. Thank you. If there are any questions, I would be happy to take it.